So good afternoon, everybody, and welcome to this third webinar of the Fungal Sepsis Training Program. My name is Pedro Povo. I'm the privilege to co-moderate this webinar with Marlies Osterman. So just a quick overview of this training program. This is the target population is the people, young people, but also people with already some special training in this area, improving the knowledge and the skills in the area of fungal sepsis. We have done 6 modules, 5 are video lectures, 3 video lectures in each module, and 1 that is almost finished is a virtual reality experience. And this program is the result of an unrestricted grant to the EasyCam from Gilead. So the program has been put together by Elie Azoulay, that is also, as you know, the president of the European Society of Intensive Care, and Marlies and myself, we are co-moderating this program from the beginning. We put together almost 30 experts in total from 14 different countries. We after opening this program, we have more than 700 registrations, and all the total the people that completed the application were 560 people from 95 countries. So this is quite a successful training program, educational activity. The majority of people are from the intensive care background, and we have already done the first 2 modules and live webinars. Today will be the 3rd one on invasive aspergillosis in different patient populations, and you will have the opportunity to have the experts with you. So the first one was understanding the basics. We had 78 participants from 32 countries. The second one was 45, which is from 24 countries. And today would be on invasive aspergillosis in different patient populations. And again, I ask you to use the chat to put questions to the experts. They are here also to solve your problem. So don't be shy, put all the questions that you think are important. And then I will hand over to Marlies, please.
Thank you. I would like to echo what Pedro already said. It is a great honor to co-chair this really exciting and very informative webinar. Today we focus on invasive aspergillosis, and these case discussions are really following the in-depth expert lectures which you've heard and already listened to by international experts. And in these previous webinars, in these previous lectures, the experts focused on invasive aspergillosis in immunocompromised patients, immunocompetent patients, and we also had a lecture on invasive aspergillosis in patients with COVID-19. And just as a brief summary, our experts told us that invasive aspergillosis is a serious condition in immunocompromised and immunocompetent patients. In immunocompromised patients, the prevalence is increasing because we obviously are dealing with an increasing number of patients who are immunodeficient as a result of transplantation or receiving various drugs for cancer or other illnesses. We heard that the diagnosis is based on a combination of host factors, microbiology results, imaging reports, and biomarkers. But there are nowadays also new tests available that help us making these diagnoses, and they certainly shorten time. We heard that voriconazole is the first-line treatment for invasive aspergillosis in immunocompromised patients. And voriconazole, very effective, requires therapeutic drug monitoring. And we were also informed that there is an increasing epidemiology now showing azole resistance globally and worldwide. We then had lectures on all the clinical pictures and epidemiology of invasive aspergillosis in patients who are immunocompetent. And again, the experts informed us that this was a serious illness and shouldn't be missed, but it's sometimes hard to diagnose. Common risk factors are steroid exposure, COPD, liver cirrhosis, and severe viral pneumonia. And similar to the previous slide, again, the diagnosis relies on a combination of different factors, including laboratory results, imaging, and biomarker results, mainly because histological information is often not visible. Voriconazole and isovuconazole are considered the drugs of choice for primary treatment. Again, voriconazole is a drug that is effective, but has potential side effects, including drug-to-drug interactions, and it requires therapeutic drug monitoring. And then lastly, we had fantastic lectures talking about invasive aspergillosis in patients with COVID-19 and in patients with influenza. Again, outlining and highlighting the fact that both conditions, so influenza and COVID, can be predisposing risk factors, that invasive aspergillosis needs to be considered in patients with these viral illnesses. And again, that bronchoscopy and bronchoalveolar lavage, galactomannan testing are the cornerstone of the diagnosis. But all experts highlighted the fact that this is a complex problem requiring expert input and a combination of tests and diagnostic tools. Current data support a strategy with initial therapy that uses voriconazole, but again, resistance is increasing in many countries worldwide. And this is really a summary of these amazing, very educational lectures which are available online, and hopefully you've already had a chance to listen to. If not, I would encourage you to go back and listen to them. And now we will discuss cases which will hopefully, I'm sure, summarize and point out some of the factors and issues discussed in these lectures. And I'll hand over to Pedro again.
So thank you very much, Marlies, for the overview of the third module. And now I will ask Anand to share a screen and to start presenting the first clinical case. And again, I ask all the people that is listening to use the chat and to have this excellent opportunity to ask questions to the experts.
Thank you, Pedro. So my case would focus on more of on the risk factor in ICU patients who are not, who does not have a classic immunosuppression. So the case is a 62-year-old smoker who was diagnosed to have COPD for the last 7 years. Recently, he's having recurrent exacerbations, with the last 2 necessitating a hospital admission. During hospitalization, he would be initiated with antibiotics and oral corticosteroids, with increments of his regular bronchodilators and inhalational steroids. So despite his illness, he continued to renovate his attic, which was damp following the winter. So since the last 5 days, despite the usual escalation of treatments, his shortness of breath failed to improve. He thus was kept on face mask oxygen in the emergency department. So the ID team was consulted and antibiotics were broadened. After the initial 24 hours, he had subjective improvement of his dyspnea with objective reduction of his fractional inspiratory oxygen requirement. So the plan was to collect his results and transfer him to the wards. But in the meantime, he started producing excess sputum and his dyspnea worsened. With a revised diagnosis of impending respiratory failure, he was transferred to the ICU. So the first question is really, when do you suspect invasive aspergillosis in a non-immunocompromised patient? So list all the potential risk factor of invasive aspergillosis in this patient. So the second question is, what further prior medical history and investigations would you request if you suspect invasive fungal infection in this patient? Outline your diagnostic workup for IA. So as you might have guessed, potential risk factors are multiple in this patient. First, he is a still smoker. So we know smoking affects the epithelial function, ciliary function. So they are at risk for colonization and invasion of fungal infections in smoker. So the second is he developed COPD for the last 7 years, and it has been known that COPD is one of strong risk factors, especially as the disease is worsened with a severe obstruction and continued smoking. So repeated antibiotics also does not help in the growth of fungal infection. So he had repeated exposure because of recurrent exacerbations. So with the recurrent exacerbations, he was put on PO steroids on top of his inhalational steroids. So even without the use of steroids, so we have known that COPD by itself is a risk factor for invasive fungal infection under appropriate clinical settings. So he also has a risk for colonization. So we know colonization by itself has higher mortality as opposed to non-colonized, and we know colonization is a risk factor for invasion. So renovation, environmental exposure with a load of high spore in the area is a risk factor. So the clinical course is also protracted. He was put on appropriate antibiotics. He did not respond. And one of the symptoms in these patients is worsening of dyspnea. So we know fever is not common as opposed to immunosuppressed individuals where fever is as high as 80% of patients. But in here, it's less than 50% of patients, like fever is not common in ICU fungal infection patients. So these patients tend to have initial mild improvement, but would worsen subsequently. So the clinical course also suggests other organisms, including fungal infection. So among his previous imaging, because he was repeatedly hospitalized recent times, I would start with his previous imaging, because imaging, if the patient has a normal imaging, then by itself it rules out invasive fungal infection. But the fact, but another thing is he has COPD for some time. So he has risks for other diseases, including malignancies with recurrent post-obstructive pneumonias and so on. In line of fungal infection, we know that acute invasive pulmonary aspergillosis is not the only manifestation. Is not the only manifestation in patients who have indolent and recurrent infections. So we have to rule out the chronic forms of cavitary aspergillosis or chronic necrotizing aspergillosis. So that really is important because we want to take samples which is representative of his current clinical condition. So lesions, recent lesions, usually taken less than 6 months old lesion, would be the appropriate site to take a sample if we suspect invasive aspergillosis.
Hadan,
So
could I interrupt you for a second? We have a question from the audience.
Okay.
And one of the people in the audience are asking whether the existence of emphysema alone is a risk factor, given that emphysema can destroy the lung and also lead to small cavities. So is this a risk factor for invasive aspergillosis?
Yes, yes. Any form of COPD is a risk factor. So emphysema, defined not only by imaging, but also has obstructive features, right? So obstructive feature with local epithelial abnormality. So on CT scan, we see the emphysematous change on the parenchyma, but all the disease occurs from the upper airway to the lower side. So definitely is also a risk factor. Thank you.
Great. Can I come back to your previous slide once more? There's another
Okay.
question, follow-up question.
Okay.
If you just go to the previous slide once more. You mentioned you at the bottom, you say that it's important to identify the site for sampling.
Yeah.
The question by a person in the audience is, when you talk about sampling, what are you referring to? Bronchoscopy, sampling by bronchoscopy, or interventional radiology, or any other method?
Depends on the location of the new lesion. So if the location of the new lesion is closer to the airways and you suspect airway lesions, which is visible on imaging, then you would, if it's closer to the central airways, then you would go to bronchoalveolar lavage. But if the lesion is nodular, close to the periphery, which is not, which does not have a good yield during bronchoscopy, then you would go to transbronchial aspirate. So depending on the location and the chance of yield for the lesion.
Thank you.
But mostly we talk bronchoalveolar lavage.
Could I just ask the remaining panel, because we've got a panel of international experts. Do you all agree, or is there something else you do in your practice or you advise your colleagues regarding sampling in patients with COPD? Jeroen.
Yes, well, I follow Dr. Hanan's example. I think it really depends on where you are and obviously in what kind of condition you find a patient, right? And obviously in ICUs where we mostly treat ventilated patients, we try to be as effective as possible, and most of the tests that we are discussing are validated for very specific types of tests that we're doing, right? So if you want to do an Aspergillus antigen, for example, then you need to really do that in a BAL fluid, and you can't do it in a normal sputum because it doesn't have that validity. So I would say that you go as invasive as possible, right? If you can do a biopsy, please do a biopsy, right? And obviously that's very dependent on the clinical status that a patient is in, and also of the ability of your pulmonary physicians and if they actually want to actually perform those tests. So I think it's really dependent on where you are. Talking from the ICU perspective, yes, invasive bronchoscopy with BAL is probably the most appropriate way to approach this problem.
Laura, in Canada, you're an expert, worldwide expert. In Canada, do you do the same?
We do. I think one of the areas, though, that gets very challenging is that clinical state of the patient. So if that person, many cases with COPD are really, interesting to manage. You don't necessarily want to intubate all of them because, that can carry consequences where you intubate somebody and they can't come off a ventilator. So a lot of times we're trying to manage them, with non-invasive ventilation. And that, I think, is where some of the challenges come in. How do you know that this is just another routine bacterial, like COPD exacerbation? When do you start thinking about invasive aspergillosis? And then how do you make that diagnosis? Because again, if they have a lot of emphysema and a lot of lung destruction, to go in and think about biopsying or, bronching these people, one, you may not be able to do bronchoscopy safely. And two, by the time, or if you talk about biopsying them, the potential for a pneumothorax and or difficulty hearing a lung that's severely damaged with COPD then makes that decision making much more complex than what it sounds like on the surface. And I think, you know, the nice thing about Hanan's talk is to really outline where those risk factors are and to start thinking about invasive aspergillosis in these patient populations, especially in somebody who's not getting better or who's had a lot of recurrent infections in a relatively short period of time and has been exposed to a lot of steroids.
And any other comment or opinion from the other experts, Laura, Jose?
I think it's just important that you don't just rely on serum samples, etc., in a non-neutropenic patient to already say that this patient does not have aspergillosis, so that you do try to get the sample, the respiratory sample, and preferably, of course, we would like to go for bronchoscopy and then a sample. And then if you get a negative result and your patient is not improving on antibiotics, then you revise also the sampling process itself. Did you do the bronchoalveolar lavage in the right side and the lesions were on the left? That you always keep in mind what you sampled and then the yield you get from your sample, and that you run the tests that are necessary, and you always think critically about the results that you're getting back in response to how the patient is responding to your therapy. I think that's important to keep in mind when you start ordering tests.
I think that it's important to suspect this infection, especially when the patient is not going well. The risk factor has been discussed by Julius' colleagues. I think that a bronchoscopy is feasible to perform a bronchoscopy in this type of patient. Biopsy, at least in my experience, is very complicated, and I would say that it's not feasible to perform the biopsy. That is the gold standard to obtain a tissue to demonstrate invasive invasion by the molds. And of course, the main tool that we have is a bronchoscopy. Regarding serum biomarkers, perhaps the beta-D-glucano is not specific for Aspergillus. It can be found also in infection caused by Candida species or even by pneumocystis. But it is useful in this kind of patient as a serum biomarker. And if the beta-glucan is positive, the patient may have an invasive aspergillosis, although the diagnosis is not obtained only by these biomarkers. I think that in my experience and the experience of the rest of the panel, serum beta-glucan is not, serum galactomannan, excuse me, is not useful in these non-neutropenic patients.
Just one comment that I think all of you touch is when we have a COPD patient that is under, let's say, correct medical therapy and is not improving. So it's the assessment of a non-responding patient. And so in here, one of the possibilities is having an invasive aspergillosis. What else should we think about? And is invasive aspergillosis on the top list of a non-responding patient? What do you think, Hanan? Where do you put in your clinical reasoning when you are facing a COPD patient with lots of risk factors that is non-responding to your initial therapy? Is it the first of the list is invasive aspergillosis? What else could be in the list?
Yeah, thank you. So that's why it's better to start with imaging. And as shown in this slide, cardiovascular evaluation is very important. So we know that these patients are also at risk mortalities related to heart failure, and cardiovascular diseases are very commonly misdiagnosed as pulmonary infections. So cardiovascular prior evaluations and current as well is very important. And this, so bacterial infections are not the only exacerbating diseases. So we have to check his vaccination status. We should not forget COVID-19 by itself as a disease or by itself as a risk factor for invasive aspergillosis as part of this current case presentation. So vaccine status for flu shots also are very important. So further workup. So it's good to do PCR for influenza and also COVID-19 PCR. So we have seen in previous lectures that influenza positivity is a strong risk factor by itself for invasive aspergillosis, but also as a worsening exacerbation risk factor for COPD. So current COVID-19 PCR status should also be unchanged.
Thank you, Hanan. Can I just ask the panel whether they have any additional comments? Maybe Laura?
Yeah, so I would add, in terms of going back to Pedro's question, that when you have somebody who's not improving, remember, this is a patient population that has fundamentally, been exposed to numbers or differences or different antibiotics. And, the possibility of the development of a multi-drug resistant bacterial infection also remains quite high in this patient population. And I think if you don't have that on top of, some of the other things that Hanan has just mentioned, that's when that diagnosis of invasive aspergillosis needs to be escalated in your mind, in my opinion, anyway.
Same is true for TB, right? I mean, patients with elderly patients with a lot of steroid use, always be very much aware.
So would you both say that TB needs to be excluded in parallel to like aspergillosis, you need to exclude the other things? So resistant bugs and TB.
Yeah, I mean, in Canada, there is a lot of TB, like in many other countries. I think, we forget about TB at our peril. I can tell you, we forgot about it in our ICU. We had a long stay patient. We didn't isolate it. The hospital was very impressed when the entire ICU team had to be tested and followed for the potential development of TB. So, you need to think about these things that come up, and now we never forget it. I can tell you that. But, that diagnostic of what could be happening, what are the risk factors for these things is very important to consider. I think we get lulled into, it's just another COPD exacerbation. And I think it's really important to bring this case forward, because it may not be, and that has profound consequences on your patients.
Thank you. Thanks for the reminder and sharing your experience.
Yeah, we never forget TB here, so just
yeah. It's the same in Spain. We also we always consider tuberculosis, of course.
Yeah. So I would show the clinical criteria later on. So that would.
Another question to the experts is, when we have aspergillosis, is it a monopathogen infection, or is it frequent to have co-infection with bacterial and aspergillus and bacterial and aspergillus and virus? How frequent do we have different pathogens at the same time in patients like these COPD patients?
Yeah, so bacterial co-infection is very common. So as said, mostly they would be treated immediately with antibiotics, but co-infections with other fungal, from my reading, it's more common in diabetic patients. So with candidemia being candidiasis, yeast infection being more common in diabetic patients, where invasive aspergillosis presents far later in the clinical course. But in COPD, it's invasive aspergillosis is very, very common, and it's usually missed, and it's one of the common cause of missed causes of mortality. So invasive aspergillosis, without other fungal co-infection is very common in COPD as opposed to other diseases like HIV and less common risk factors like diabetes.
Any other experience from the other experts on this? Is it Aspergillosis appears isolated, is frequently as a co-infection or co-infectant another pathogen?
I think it's different in the immunocompromised patients, right? There's often a coinciding infection with we may discuss that later on today, but with for example HSV in your ICU or a recurrent COVID, right? So you're not able to clear your viral infection. So I think that's definitely something. It's an indicator of microorganism also for immunosuppression, right? So that remains. I must say that my experience with COPD patients and Aspergillus is pretty limited. I don't see it that much, to be honest. So it can also be an epidemiological thing that you know makes it more common in some areas than in other areas. It's not, to be honest, I mean, as a clinician, it's not really the first thing I think of when in an exacerbated COPD patient. It's important to recognize, but it's not, I don't see it that common.
It's I mentioned it on my lectures. It's picked as a risk factor based on autopsy studies because clinicians don't usually consider it as a strong. So they think of it as a risk factor, but they don't consider it as a very strong risk factor by itself. So it is based on 25 years retrospective, a huge autopsy study, which had close to 900 samples taken, which identified around 44% of autopsy proven Aspergillus infection, risk factor being only COPD. So during that autopsy study, no other concomitant fungal infections identified. So subsequently in clinical criteria, which I plan to mention subsequently, in ASPA ICU study, they also found that COPD was one of the missed risk factors, underestimated risk factors. Most had exposure with systemic steroids, but even those who does not have exposure only to inhalational steroids were found to have invasive aspergillosis. But invasive aspergillosis, because now our focus is on ICU patients, we emphasize on acute invasive aspergillosis, but they have, depending on the local immunosuppression in their epithelium, the clinical manifestation can be protracted as well.
Should we move on and listen to the end of the story from Hannah?
Okay. So this is a patient from European Respiratory Society, a case based on the workup. So what the third question is, what should be your subsequent investigations? So here, this is a patient with results of subsequent investigations. So chest X-ray, as you can see, there are some nodular changes on the right side where there is consolidation on the left lower basal chest. So chest CT was done. So they found out nodules around here and consolidation around here. So one of the take-home message is in COPD patients or in non-neutropenic patients, because they have adequate neutrophils. So if you do pathology tests, you'll see floodings of neutrophils. So you don't expect the typical nodule, halo sign, and so on in non-neutropenic patients. So you can see a necrotic center with consolidation, which clinically is non-resolving pneumonia. That is how COPD patients present. So subsequently, they did bronchoscopy here. Here in the center, you can see there are pseudomembranous nodules and close to the carina, which is brownish in color, and it extended to the right main bronchus. So they did a biopsy here, and they have shown are under necrotic background. They can see the typical acute angle bifurcation hyphae with aspergillus. So this is a COPD algorithm suggested because it is not part of the clinical criteria, European criteria, where the risk factors mentioned are more in risk immunosuppression. Here, we don't usually do histopathological, so the proven cases are less limited. So based on this case discussion, our patient has a probable invasive pulmonary aspergillosis. So this is a COPD patient, usually treated with steroids. Mostly it is in severe cases of GOLD stage 3 or 4, but still GOLD 2 cases are also at risk. So with recent exacerbations of dyspnea and suggestive chest imaging, so radiograph or CT scan with a change, relative change in less than 3 months, and one of the following. So you can take a positive culture or microscopy from lower respiratory tract, serum antibody test, or serum galactomannan test. So if you have one of these under in the clinical settings we mentioned, so this is a probable case of invasive aspergillosis. But as a whole, you can take these alternative clinical criteria. The most important thing here is you don't start with risk factors, because COPD is not under the European guideline as a risk factor. So you start with lower respiratory tract specimen. It might be a culture, but subsequently also you can take BAL galactomannan positivity as an entry criteria. So what you have to do is you do bronchoscopy, you take lower respiratory tract. If it is positive and you have compatible signs and symptoms, so among the signs and symptoms, our patient has this worsening respiratory insufficiency in spite of appropriate antibiotics therapy. But other patients can present with fever, which is refractory, at least 3 days of appropriate therapy, or recrudescent fever after defervescence of after 48 hours, and other symptoms as well. So the third is abnormal medical imaging. So it should not be a specific imaging abnormality. Any abnormal medical imaging with evidence of aspergillus infection on a patient who has appropriate clinical settings should be considered as a putative invasive pulmonary aspergillosis. So if you take the host factor, so our patient fulfills the glucocorticoid treatment as a host factor, but if you don't have prednisolone equivalent dose of more than 20 milligram per day, so another criteria which is should be fulfilled is semi-quantitative BAL fluid positivity without bacterial growth or without other organism identified, including resistant bacteria. So if you have this, then so it's a balance between early treatment of these patients and as to avoid unnecessary days. So this is a summary. So IA is one of the leading cause of misdiagnosis and mortality in non-neutropenic critically ill patients. So these are the common risk factors. So main clinical sign in COPD patients is non-specific antibiotic-resistant pneumonia, mostly associated with exacerbated dyspnea. So as mentioned from the panelists, antigenemia is because the patients have neutrophils, they don't have antigenemia as commonly as neutropenic patients. So fever and antigenemia are present in less than half of IA patients in ICU. So this is my take-home message. Thank you.
Well, thank you, Anand. So I think this is quite an interesting case, just to reinforce the idea of a non-responding COPD patients. So think of invasive aspergillosis and also the importance of having good sampling, otherwise, and also good imaging to think about this. And there is no additional comments, I would hand over to Göran. I think that you have the slides. And just to here you can vote. So just Göran, go ahead and explain how to do it. It's
Thank you. Thank you, Pedro. Thank you, Marlies. To elicit a bit more discussion, we are using menti.com, and you can actually use the QR code here and enter the or go to menti.com and enter the code. So we're going to have a couple of questions that are going to be posed to you. So please do that. You can do it from home. On your phone. You don't need anything extra with it. So I'm just going to wait until we got a couple of people online here. There's only one person that actually put on the code, but we're just going to wait for a couple of minutes and until most of you are actually online. There's a lot of people coming on now. Excellent. All right, so
you can use your camera, or you can go to menti.com and put the code in the browser.
in the code screen, yeah, absolutely.
It's
So
a lot of fun, I was going to say. So, sign up, because this is like one of my favorite parts of when we teach is using menti.com.
okay, so just to revert back, so we've heard a bit about IA in non-immunocompromised patients, and the risk factors were actually all lined up by Hanan, and the case that I'm going to present. I'm going to get started because you can use this also later on. I will show you the slide later on, but I will start with the presentation. So I'm going to present a study of a patient that did not have any risk factors at all that had been recognized firmly. And it's interesting to see what you think about it. So this is a woman of 58 years old. She was actually treated in another facility close to the hospital where I work. She was known with hypertension and non-insulin dependent diabetes. She was an obese patient, and she presented quite some time ago already in 2019 with a cholecystitis, which was then treated percutaneously. I'm not sure why that was done exactly, but it was drained. And then 7 days after the drainage, they performed a laparoscopic cholecystectomy there. Now that went all wrong, as you can see, because the day afterwards, she developed a biliary peritonitis. There was a leakage, and she had a laparoscopic treatment done, and then that didn't work, and she got a laparotomy, an open abdomen, where the duodenum was perforated, and in the end she ended up with as you will recognize these patients, sometimes you have them a period of a long-term drainages of multiple abscesses that she had. So this took about 3 weeks to sort of develop, and in the course obviously she developed multiple organ failure, AKI with renal replacement therapy, and she actually had an episode of blood cultures with Staph aureus bacteremia, which was treated. And then on day 25, they isolated Aspergillus fumigatus from the bronchial secretions that they took. So my first question is, what would you not do with these results? So you have a patient that is in your ICU for 3 weeks for a completely different condition, and then you do a sampling from your just a normal bronchial sampling. And I would like to ask you what you would do. So these are 5 different options for diagnostic strategies or management strategies, and I'm very curious to know what you will do. So if you haven't found the code yet, please go to menti.com and you can fill in your code. And then let's see what you're voting. Okay. So we see that most of people would actually not wait and see. and would say that this is not normal, right? We should probably do something. And then there's the second activity is performing an Aspergillus antigen, a galactomannan, on the bronchial secretion. So rather than just having a culture done, which was done here, right? Performing also an Aspergillus antigen on that sample. Then there's a group that says, yeah, we should definitely do a bronchoscopy and a BAL, but almost nobody would start antifungal treatment immediately. And most of us also think, yeah, it's probably a wise idea to do a CT scan. So I'm curious to know what my colleague experts think of this, but maybe let me hand back to Pedro and Marlies. Jose, would you still consider this colonization of the respiratory tract in this patient?
Who wants to
You're
answer?
on mute.
Yeah, Jose, you are muted.
Yes, sorry. Yes, it might be considered colonization, but I think that I think that we have to follow the idea that the patient can be infected. So I think that other analysis like bronchoscopy or a CT scan should be done.
Yeah.
Does
I
anybody
agree.
I would also go for the bronchoscopy and the sampling, and I think the CT is also wise to perform. But I would rather see this culture coming from a BAL than just from the bronchial aspiration. And I would like to see the galactomannan. I would like to see the bronchial tree. So I would definitely go for bronchoscopy in this patient. And not just perform the Aspergillus antigen on the bronchial secretion because it's not validated for this analysis. So you wouldn't really know what to do with the results, and you wouldn't see the bronchial tree. So I would definitely go for the second part and then try to get the CT as well. But I don't know in your ICU how fast you can get the results and how transportable this patient with multi-organ failure is, of course.
I think that all of us agree that we cannot determine the galactomannan in sputum or in tracheal aspirate. We should do a bronchoscopy. But now my question for the rest of my colleagues is, and what about a mini valve? What about a mini bronchoalveolar lavage? Do you use or can be used in certain situations? Is the same the cutoff for the galactomannan? What's the validity of a mini valve? Because at least in my experience, some of my colleagues in very sick patients with very severe hypoxemia consider that mini valve could be an option, and probably some of the attendees also have the same idea.
Can you elaborate on the advantages and potential disadvantages of mini valve versus BAL?
Yes, mini valve it's easier to perform, and probably if the patient, if you don't have a very skilled bronchoscopy, if you have a very skilled person that can do the bronchoscopy, it can be done. But sometimes you don't have that colleague, that physician in the hospital, especially on weekends, or because in your hospital you don't have that resource. And you always can do a mini valve that is you can do it in a very short period of time. You don't need a very special skill, and it could be something better than a tracheal aspirate. That can be probably the situation of the mini valve. So
yeah,
Jerome?
Yeah, well, Jose, I have the same discussions in my own hospital, and I think I think that Laura mentioned something that's very important. You don't look at the bronchial tree, right? You don't get a look, and I think that's very important because it can really make a big difference. That's my first reason why I always try to do a bronchoscopy if it's possible. The other thing is, if you are doing a bronchoscopy and you think that it's too risky to leave behind like 200 mils of fluid, right, which is, you know, or even more, then my own experience is that you can do a BAL. You can always do a BAL if you in terms of the risks. I think that may be a little bit over emphasized. I think it can always be done, but you may need to use less fluid, and it's accepted to use a bit less fluid, but at least you have a well-positioned bronchoscope, and I think that is something that can really help. So this is what we do when we have a patient that is very sick and you know, the pulmonologist is afraid to perform it. We say, well, I'll take a look at the bronchial tree. At least that's not so hard. You can do that always, and then do a selective BAL that doesn't have that same amounts of fluids. But I'm curious to know what, for example, what you do in Leuven, Laura, if you take that kind of way out.
Yeah, we do have a low threshold to perform bronchoscopy, but indeed we do use not the typical immunology sampling of amount of fluid that we do in our ambulatory patients that do not require oxygen. So we don't do, we typically try to do at least 40 milliliters of fluid.
Yeah.
And we do still see good results with that, although that hasn't been validated or hasn't been tested formally. And in most studies in ICU patients, you don't even see exactly the amount of fluid that is instilled and it is recovered. But I would say that at least go for bronchoscopy, try to get some fluid in and some fluid out, of course, but don't go for like the immunology type of sampling with lots of fluid installation. But well, I was thinking about what do you mean with mini bulb, because, well, you could say that's kind of a mini bulb because you look at the bronchial tract with your bronchoscope and you do a mini amount of fluid or a minimal amount of fluid that you think is still relevant and still gives you quite a deep entry into the airways, of course, as well.
Yeah, I think the term is non-directed BAL, right? So then
Yes.
then it's you know, it's blind if you want. You just put in
Blind.
cannula and you just you know. So again, well, Laura, any comments from your side?
I have a question with this patient, and maybe I'm going to throw this open to the participants. Were you surprised by this finding? Like, if we were going to think about fungal infection, would Aspergillus be the one that comes to mind in a patient like this? Maybe people could use the chat to sort of share what they're thinking. Anyone? Don't be shy. You know, I'll start off by saying I was surprised. It's not what I would have predicted you would tell us in terms of where and what kind of fungus that you would find.
Sure.
Can I ask the same question in here? In a patient like this one that is not improving, what do you think? Is it Aspergillus that come to your mind on the top?
Well, we surely didn't expect this, but and I think we would have expected to maybe answer to Laura is that we would have candidemia or something coming right in this patient, which we didn't. I mean, but it posed the same questions as I've put here. What are you going to now do with that, right? Are you actually taking this seriously? And I remember that we were discussing this patient, and half of our staff said, nah, just colonization, let it go, nothing on. And this patient wasn't very ill, right? This patient was obviously continuously ill because she was on the ventilator for 3 to 4 weeks, and then we you know, we sort of had some quarrels about whether we should actually do by diagnostics, but. Just to add on one thing that we haven't discussed, so only a very small proportion of the responders said, well, we would start immediately with antifungal therapy. I'm curious, in the experts, is there anyone who would directly start with antifungal therapy in this patient?
Well, if she wasn't getting better, I must say that I would certainly consider it at this point, but more for an abdominal source that would be Candida, as reflected in the chat by some of our participants, or you know, some fungus along that line, you know, varieties of Candida. And I don't think I would have leapt Aspergillus.
No. Yeah. Well, I wouldn't. I probably wouldn't have. I think I would have wanted at least more information on the on the invasiveness of this, all right, and at least have some, and of course, if this is a patient that was severely respiratory and severely respiratory distress or had some other of those symptoms, then I might have been tempted, but in our case we didn't. Shall I move on, because I think that so this was the X-ray, and of course, I mean, that's sort of very well. An ICU X-ray, I would say, after 3 weeks, could be anything. And this was the CT scan. So then obviously people started thinking, okay, well, maybe that's not so nice what we're seeing here. And as a matter of fact, on day 28, we discussed and we said, well, let's do a bronchoscopy. Now, the question to the audience is now, what kind of tests would you order in the BAL fluid? So you're talking to the pulmonologists, and you're saying, okay, I want you to take on these tests. And I'm not talking about, you know, normal bacterial cultures, et cetera, but mainly dedicated to what you found in your bronchial aspirate. So most people have really paid well attention to the videos, I guess, and I agree that most people would do a culture and an Aspergillus antigen. I still see quite some people doing a beta-glucan in BAL. Has anybody got some experience with that? I've never done that. Is there any reason why we should do that? Maybe Jose, do you have?
No, we have a beta-glucan in blood, but not in respiratory samples, not in bulk fluid. I know that it is described to use or to measure beta-glucan in blood fluid with a very good results compared to similar result to galactomannan. But in my hospital, we decided to perform beta-glucan only in blood.
Yeah. Same here. I'm not sure if any of the other experts would like to comment on this or on the other cultures and tests that are done. Are we missing something?
I will specify about Aspergillus antigen, about galactomannan, especially because it can be measured by ELISA in several days, 2-3 days, but we have the possibility to perform in less than an hour in a lateral flow. That is a immunochromatography test. This test, earlier on, they determined the glycoprotein of the Aspergillus, but I think that nowadays in the majority of the hospital, at least in Spain, it is determined the galactomannan, and we have the results in less than 1 hour or 2 hours since the bronchoscopy was performed. And I think it's very useful because there is a very good correlation between galactomannan measured by ELISA and the determination by lateral flow. In our protocol, we also include staining with a white chalcofluor that is very easy to perform, and probably it doesn't add any more than galactomannan by lateral flow. But we also perform the white chalcofluor to stain the molds.
Thanks. I'm just curious to know if everybody uses this lateral flow device. I think we've used it. I mean, during COVID, I think it was used a lot. I know that Laura, you've mentioned a bit in your presentation on this, on the sensitivity, specificity in different kind of cases. In this case, would you be more cautious than in the classical IAPA case or other cases?
Yeah, that's a very good question. I might, I think I would probably use it with a constellation of other investigations that you've outlined to be more confident in the results in this case. You know, I think that with the imaging, you know, and the whole clinical spectrum would make me much more confident in the results than using it in and of itself in this particular case. Just, you know, as they develop more, I think the sensitivity and specificity are going to improve. I think they're very exciting tests. But I think we need, you know, we need more time with them.
Yeah. Laura,
And what is the turnaround time of the ELISA test in your setting? Because that's could be also a point.
That's a good one. Yeah.
I think in our hospital in Leuven, we do not use lateral flow on ICU. We have a very good turnaround time. So every sampling that has been performed prior to noon gets the result in the afternoon, except for tests being run on Friday, Saturday, or Sunday. And we don't really have the good infrastructure now to have the ICU staff, the nurses, to perform the LFA. That being said, I know of other hospitals in Belgium that do use LFA, and it has been validated in BL samples of ICU patients, non-neutropenic patients, although I think the data is a bit bigger also in the viral pneumonia setting and the Kappa setting. Yeah, it kind of depends upon, I think, indeed, how your local laboratory is working and how fast you can get results. And I think we could use it here and maybe have it as a first test coming in and then have your ELISA measurement later on coming in. It really depends on how your local setting is. But in our hospital, because we have this very good turnaround time, we don't really use it on ICU just yet. Yeah.
I think the same is true in my own hospital. We have a bit the same constellation. It looks like we're going to be using it much more, but indeed you need a point of care structure in which you can actually apply it. I just had one other question. It's on the PCR. I see that not everyone in the crowd who's looking would ask for Aspergillus PCR. What would you guys do? I'm not sure. Maybe Hanan, do you have a possibility in your center to do PCR? And do you in every sample that you take from a BAL?
No, we don't do routinely PCR tests, no. So we do antigen tests. We start, in our setup, we start with imaging. So with imaging, we see features of invasion. So in case we don't have appropriate samples, we rely on the pretest probability, which is less in these patients, but in immunocompromised patients, if the patient has high pretest probability with imaging suggestive of invasion, then we do bronchoscopy and we do microscopy. So you see microscopy, the features, even you look at the epithelium, and if you suspect, then you go to the antigen test.
Yeah, so Blancophore. Yeah, we actually do Aspergillus, but that has to do a lot with resistance because there's obviously some strains that have mutations that are recognized as specific for resistance, and I think that sometimes helps us if we don't have a culture become available or it doesn't grow, that we still would have an idea about resistance rates, but I'm aware that that is different in different settings.
So Jeroen, what happened next?
Yeah, let me move on, sorry. So this is the bronchoscopy. As you can see, quite impressive, a diffuse tracheobronchitis covering the mucosa. So there was a biopsy performed actually from the corona. We don't bother too much about biopsies. We have pretty active pulmonologists who do that, and then it showed actually negative culture and a negative PCR, which was a little bit strange. And then the galactomannan was positive, serum galactomannan was negative, and we started this patient on voriconazole and liposomal amphob. That has a lot to do with our resistance rates. But maybe we should, if we have the time, you stop us when we have to, right, Pedro? Maybe this can be the last question for this case.
Yeah, but the discussion is okay.
Okay.
No worries.
So, so what do you think about empirical therapy here? So we had the discussion when we had these results back. So cultures were negative, PCR is negative, there was a positive galactomannan. Well, some said, well, wait with treatment because cultures are still negative. And then someone said, well, voriconazole monotherapy is the preferred treatment here. And the other said, liposomal amphob is the preferred treatment. Combination therapy was discussed, and then amphotericin nebulizers were also suggested. So I'm very curious to know what your approach would be to this clinical setting.
Okay, we don't use.
Yes, come on. Jose, go ahead.
Go ahead.
Okay, we don't use nebulized amphob. We don't use. There are some problems with the use of liposomal amphob nebulized. We don't have that strategy available in our hospital. I think that it makes sense to use nebulized amphob in this case of patient where the trachea is probably involved, although the biopsy and the PCR was negative. We use as first line isavuconazole in these in critically ill patients. Fortunately, we can measure voriconazole cellular levels, but despite that, we have this technology. We use isavuconazole. And in case of a combination, we prefer the combination with amphob, with the liposomal amphob, as it was done in this patient.
Hiron, can you discuss a little bit of the issue of resistance, special resistance, and the regional differences on that? I think that's important in empiric therapy, let's say.
Yes, I think it was discussed also in the video that we made earlier. I think what we see in the Netherlands is that we have on average a 15 to 20%. Well, sometimes it depends a little bit on the place where you are, but it's quite some azole resistance. And obviously at the start of treatment, we don't know yet if these are resistant strains or not. As a matter of fact, it could also be that in one part of the lung there's a resistant strain, and in another part of the lung there's a spore that came in and that was not resistant. So this is a difficult diagnostic part, but that means that on empirical treatment we have no other choice than to treat, and the combination with voriconazole and amphob is chosen, or a combination of voriconazole and echinocandin is chosen. Those are the options that are given by the Dutch guideline. I think it doesn't, I mean, I'm very, very much agreed with voriconazole monotherapy being the preferred treatment. I mean, if you have an azole sensitive aspergillus, then absolutely you should treat it with voriconazole or isavuconazole. I mean, because the data from the trials do show that in that case that azole therapy is superior. But of course, if you don't know, then you have to have a backup plan, and that is in our case that is combining it with another effective antifungal. And maybe to react a little bit on the amphob nebulizations, there's not a lot of evidence in the field. I agree, and I'm aware of that. We do use it, but only in cases where we see a tracheitis like it is seen here. So we don't regularly use it in patients who have a positive galactomannan but don't show this large and important tracheal depositions, right? So it's really in an effort to reduce the load of mold that you can find there, but it's the evidence is pretty limited.
I think it's an interesting case with a very severe tracheobronchitis because it's not, the patient doesn't have any typical risk factors, and this type of Aspergillus manifestation is typically seen in lung transplant patients or AIDS patients in the past, and now with influenza we see it also quite a lot, and then in COVID-19 a bit less. But I do agree with the local amphotericin B nebulization that maybe you want to get some kind of local reaction because you suspect that it's very necrotic tissue underneath, and so the amount of antifungals reaching this area is probably through the systemic way is probably quite low as well, and then you would like to add something inhalation wise, and now there's this novel azole therapy in development for nebulization, but that still requires quite some testing, the opalconazole, but I think it's interesting to add the amphotericin B nebulization, or at least consider it in this very severe case of tracheobronchitis.
Yeah.
Can I ask, Gerard?
Yes.
What happened to his peritonitis?
The peritonitis was actually that was actually well controlled. So this was during the rest of the stay, there were no issues anymore with her peritonitis. That sort of recovered. She was on the recovery part. Let me just show you what we did, because I think it's maybe interesting. So this patient was, as I said, was in a poor condition, but even then in prone position because of poor respiratory failure. And despite the start of voriconazole and Ampho-B, she didn't actually get better. And after a week or 2 weeks of treatment, 1.5 weeks, we did a repeat bronchoscopy under therapy, and the galactomannan actually only went up in the BAL. Also, still the culture and the Aspergillus PCR remained negative, but the biopsy showed extensive hyphal elements in the necrosis. So we still had to treat this as an Aspergillus. And then, well, let me just skip this one because maybe that takes too long. But what we did was then we said, well, we probably going to need to evaluate what is going on. Is this patient then in some way immunodeficient? So we obviously did the test that Laura, that you said, HIV, all the other aspects. This patient was not on a long-term steroid therapy. It was actually just a patient that was in the ICU for a very, very long time. So thanks for all the answers. I will go on a bit to show you what we did, because I think we did exactly what you wanted. We were thinking, well, we've treated now for 1.5 weeks. Should we still wait, or should we do something else? So nobody suggested steroids. I think that's right. Discontinuing treatment, prognosis is poor, is maybe a little bit early, right, in the process. And we did what we do in our hospital is that we look at HLA-DR expression, and we saw that indeed the expression was very, very low, and it's sort of a sign that it's a sort of a value that helps us understand ICU-related immune paresis. And as you can see, the normal donors, if you want, have an expression that's much higher than this specific patient. So what we did, and this is, I recognize that this is not.
Can I just interrupt you?
Sure.
Did the patient have also lymphopenia at the time? Can you remember that?
Yeah, also had lymphopenia. Yeah. And so we then said, well, why don't we just start give this patient interferon? And we started this patient on interferon for 2 weeks, and we did that 3 times a week, right? So this is not normally done a lot in ICU. We started with it, and when we saw that it didn't really increase, make it better, it just improved a little bit, we increased the dose to 100 micrograms daily. And then, to be honest, I'm not sure. Obviously, there's a lot of thinking about this, but it looked like at least the immune paresis sort of restored a bit, and the patient got a little bit better over time. Obviously, also on treatment still, of course. and we repeated the BAL, and at that time the galactomannan actually went down from 2 and then later on to 1. And in biopsy, then we performed actually the Aspergillus cleared over the course of time. Again, this is a long time, right? We've been treating a patient for weeks and weeks in the ICU. So on day 50, actually, we stopped the interferon and continued the antifungal therapy. But unfortunately, on day 60, the patient got quite acutely unwell with inspiratory and expiratory stridor with a CO2 retention, and was unable to ventilate, very difficult to ventilate. We performed a repeat endoscopy, and this is what you saw. It was completely obstructed with mucus, with bloody discharge, very likely related still to either we never did a abduction in this patient, but it looked like this would have been because of the same problem that we had before. So yeah, that necrotic tissue in the lumen, and there were no therapeutic options anymore at that time, and we resorted to palliative sedation, and the patient dies. But I think what it shows, this case actually shows that even in a patient who's been on the ICU for a very long time, and this is not the first case we've had once in a while, we had cases like this, that you can actually develop a status of immunoparesis, it's sometimes called, in which you're more likely to get invasive aspergillosis infections, and actually presenting in the way it does here, very extensive with tracheitis. And unfortunately, this patient didn't make it, but we have seen patients who actually got better after also providing them with immunomodulation, like with interferon.
Göran, can I ask a question? If you didn't have HLA-DR testing, would you have gone on the premise that perhaps, maybe not after a week and a half, but say 2 weeks in, 3 weeks, that there was yet more Aspergillus resistance? Like, would you have pulled out the new emerging therapies at that point and tried to get, in Canada, we would need special release. I'm not sure how it works in the Netherlands.
Well, I must say that in my hospital, we don't have easy access to those, easy access to those really new drugs. I know that we have had a compassionate use case where we did, but it's definitely something that went through our minds, obviously, but we did, and I haven't shown in this slides, but we did do resistance testing, and all the samples obviously were negative. So that was I mean, that was on the first, remember on the first culture we got, it was a voriconazole sensitive microorganism. So we didn't actually change the therapy. The patient was on broad spectrum therapy the whole time. So but I do remember now that indeed after we had the bronchial biopsy, I think in the end we still managed to get a culture, but this was at 40 days or something, and that was a sensitive culture. So yeah, I obviously something to discuss, but emerging other therapies we don't have easy access to.
So I think one of the thing that we have from here, we are always learning, and again, this is the interaction between the host and the pathogen. And again, the question is, in the future, would you consider to perform the HLA-DR testing in the beginning and not waiting, or only in patients that are again non-responding?
Well, I think, Pedro, that's exactly what we're trying to do more and more in ICU, is to look at, especially in patients who, I mean, you wouldn't expect it in a patient that's in there for the first week, right? But indeed, if we have patients that are on the ICU for a longer time, that is something that we increasingly do, especially when we start to pick up like indicator organisms like HSV or non-resolving viral infection or Aspergillus, that we start thinking about that earlier. And obviously the problem is a little bit is how do you appropriately evaluate such a patient, right? You can look at lymphopenia. Indeed, you can look at this HLA-DR expression, but there's no holy grail in this, right? I mean, the obvious immunosuppressive agents and syndromes that we know do not really count here. So yes, we do it quite easily, but that's also because we have a research group that does a lot in this field, and that's why we assess it. But I'm not it's difficult to have sort of a general recommendations on when you should do this, and especially also on the treatment with interferon. That is something that we just do out of an idea that may change the situation, but it was a little bit of a back against the wall measure, I will say.
Yeah, there's a question from Marga Gillen asking if are there other immunological status tests to check the in addition to the HLA-DR lymphocyte subsets, maybe some populations, I don't know, PD-1, PD-L1, I don't know, what do you think?
Well, I maybe Laura, you can say something about that, because it's really not my topic of expertise. Okay. But Laura knows a bit more about that.
Yeah, I think there's, like, in routine care, not much you can actually study, and not in a resource setting, like Jeroen is talking about the HLA-DR test. It's not in our hospital that we perform it in routine care. We don't use it actually at this time point, even in our research setting. Although it's a very, well, this is one of the tests that has been shown indeed that is a hallmark of immune suppression in different settings, specifically in ICU patients. But to do other type of tests, I would just say that indeed go for the obvious ones like HIV and try to, like, get a view on that. And then, well, it's very difficult because even in research setting, we're still wondering what do we need to think about all the evaluations done in blood, and how does that correlate with the immune status in the lung of the patient? And we have some data coming from BL samples and immunological testing, like in influenza and COVID-19 patients. And we're still trying to work out, like, what do we see and how does that correlate with our clinical image? And I think we just need more time and more research funded in this sense to get a better view. Yeah, testing for your neutrophils is just something you do ordinary, but that doesn't really say anything about the function of the neutrophils or the exact phagocytotic function or the autophagy, etc. So I don't think there's anything you can really do in routine care at this point in every hospital to get a better view, other than the typical tests you always do, really. And then
Laura,
just yeah.
Can I ask, what about using CMV reactivation as a potential marker?
Well, that's also a really good question. And indeed, as Jeroen also said, HSV in the BL samples is now seen more of a marker of maybe some immune paralysis going on in your patient, projected viral course. And then CMV is also something that we see quite frequently popping up in the BL fluid of our critically ill patients, like also in influenza and COVID. And we're still trying to work out what does that exactly mean, and CMV is a difficult one, because even in your very immunocompromised patients, a CMV in the BL, what does it mean? Is it really a CMV disease, or is it more of a marker? I think we still need more research looking into that. But of course, if you get all these different markers coming up, the HSV, the CMV, the Aspergillus, this is a warning sign that something is going on in this patient, and you need to look a bit further and not just discard the results as being colonizers or non-pathogenic. Yeah.
Thank you very much. I'm afraid we've come to the end of our scheduled time. The discussion has just proven I'm sure we could go on forever, because clearly this is a very complex area where we're all learning from each other, and I've certainly learned quite a lot during this discussion from you as experts. It's an evolving field where things are changing and new findings, new research emerges, and we clearly learn from each other. I've very much enjoyed the case discussion and the various Menti options, finding out what clinicians at the bedside do. I would like to thank all of you for your presentation and your contribution. And I hand over to Pedro for the final words.
Yeah, thank you very much. I think we went through a couple of cases again that help us to think and to because we have lots of unmet needs and things that we still don't know, and this area is quite interesting. I think also thanks to the second case that brought us the issue of the immunoparalysis and how we can boost our immunity to treat also the infection, because we don't rely only on antimicrobials, we need a host also. So that's quite a good example on that in a previously healthy patient. And so I thank you all the experts. I thank you all the attendees for the questions. And I wish you also a good afternoon. Thank you very much.
Bye-bye. Thank you. Thank you.
Just a reminder, the next session, the next case discussion will be at the end of the month, thanks to our technical support in the ESICM and an educational grant from Gilead. Thank you, everybody.
Thank you.
Bye-bye. Thank you.
Bye.